Okay. Hi, everyone. Thanks for joining us this afternoon. My name is Cynthia Giwa. I'm the marketing director at ProPublica. Welcome to what I know will be a very informative conversation on the coronavirus and racial disparities. I hope you've had a chance to read the story that our panelists will be using as a springboard for discussion. It's called COVID-19 Took Black Lives First, It Didn't Have to. So today we'll hear from a few of the journalists who worked on that piece and one of the medical experts that they interviewed for it. So here on your screens, we have ProPublica Illinois Editor-in-Chief, Louise Kiernan, ProPublica Illinois reporter Duaa Eldeib, just wave, ProPublica reporter Akilah Johnson, and our guest, Dr. David Ansell, who is the Senior Vice President for Community Health Equity at Rush University Medical Center in Chicago. Dr. Ansell has spent decades documenting the life expectancy gap between Black and white Chicagoans, which is the largest in the country. So it's really great to also have his insights and expertise here for this conversation. Our speakers will also take some of your questions today. Some of you emailed me in advance, but if you'd like to submit questions at any time during the webinar, just click the Q&A icon at the bottom of your screen to type it in, and we'll get to as many as we can in the hour. But first, I'll throw it over to ProPublica Illinois Editor-in-Chief, Louise Kiernan. Louise?
Hi, everyone, and thank you for joining us for this conversation about a very important topic. Let's jump right in. As the coronavirus pandemic has spread across the United States, it has disproportionately struck communities of color. Preliminary data in New York shows that the virus has killed Black and Latino people at twice the rate it has killed white people. In Los Angeles, Black residents make up 8% of the population and 12.5% of the deaths due to coronavirus. And here in Chicago, the racial disparities have been particularly stark. As of yesterday, African Americans account for 48% of the deaths due to coronavirus, although they make up just 30% of the city's population. That gap was even worse in the early days of the pandemic. Of the first 100 recorded deaths, 70 of the victims were African American. Here at ProPublica Illinois, we wanted to understand why that was happening, so we decided to dig in. Which brings me to you, Duaa. Tell us how and why you decided to pursue this story.
So back in March, when everyone was trying to figure out exactly what this virus was and what impact it would have, ProPublica decided that we wanted to focus on racial disparities. And I remember having a Zoom call early on where we discussed it and where we acknowledged that, there was still a lot we didn't know about how this was going to play out in communities of color. But based on everything we did know about our healthcare system, about structural racism, about high rates of underlying health conditions, we knew that we needed to begin reporting right away. So I started reaching out to doctors and community organizers and public health experts, and they said yes, they were in fact seeing what we expected, but we wanted to go beyond the anecdotal. And so we filed a public records request with the Cook County Medical Examiner's Office to get detailed data on COVID-19 deaths. And that's where we saw, Louise, as you said, that Black residents made up 70% of the initial death toll in Chicago, even though they only made up 30% of the population. And so we decided to focus on the first 100 as a way to really allow us to dig deep into these stories and to help understand the context and the history. And we called reporters across the country, and we decided, let's just get to work.
And Akilah, you had already done some of the earliest national reporting on racial disparities in COVID-19 cases, looking specifically at Milwaukee. What had you learned from your reporting there?
Well, actually, we started out looking much broader, right? And so initially, I was involved in that same conversation that Duaa was, as we were as an organization. And she and I were involved in some very early kind of initial conversations about really, how is this thing playing? Sorry, and you may hear an ambulance going by in the background. That's what happens when you're live and doing this from a work from home environment. But so one of the things that we initially started to figure out is and having these conversations with people where is the data, right? That is a conversation and a question that continued to come up as we were talking to community health researchers, epidemiologists, experts who sit at the intersection of race, public policy, and then also public health. Where is the data? Anecdotally, we know if we're looking at who suffers most severe consequences as a result of COVID-19, if you're looking at these comorbidities and you look at the populations of people who are disproportionately impacted by those comorbidities, like naturally, one would assume that communities of color would be hit, but where was the data backing that up? That's what led us to Milwaukee, because they were one of the few places that had the data that we were able to then answer that question. And even with looking at Milwaukee, and the reason they had that data is because as a city and as a county, they very much decided to take an equity lens and a health equity lens to how they govern. And how they govern as a city and a community, that also impacts how they are going to respond to a public health crisis. And so that meant being very transparent in who was being infected by COVID and who was dying from COVID. And so they had early data that really disaggregated that by race, by ethnicity, by comorbidity, by age. So we were better able at the early stage to kind of say, yes, this is impacting communities of color in these variety of ways. And then with Chicago and what Duaa was able to do, then we were able to take it to a much more granular level and get location information in terms of where people were getting sick and where people were dying and where they were falling. And so it was very much an important next iteration of the story.
And Dr. Ansell, that brings me to you and to your expertise on the gap in life expectancy between Black and white Chicagoans. Can you tell us a little bit about what that looks like here and what role you think it might be playing in the pandemic?
Yes. Well, first of all, the news of excess Black mortality from COVID-19 was shocking, but not a surprise in our city or even the national the national news about it. So I think that should be just put out there first. And you think a virus that we can all get and affects us in some ways, it can affect us all, for it to be so disproportional sort of somewhat boggles the mind. But what's happening on a day-to-day basis, a week-to-week, month-to-month, over 100 plus years, has been a slow disaster, a natural disaster that's been a disaster of health inequity that's been rolling along, under the radar for generations. So in a sense is what you notice, and I think I mentioned this in the piece, is what happens in an epidemic moment is that the covers are pulled back on the social form of our society and our world. And in the United States, it's been especially true that who lives, who dies, is a matter of, lies at the intersection of race and poverty and health, in a sense that they're intersectional. So one of my work has been to look at these, I call them death gaps. I wrote a book a number of years ago, 2017. It was called The Death Gap, How Inequality Kills. As a doctor who's been trained in the biological, in the behavioral determinants of health, and we think of the world we live in of precision medicine and all that, it really struck me from my own patients that something else was going on. And it had to do with the neighborhoods they lived in. It wasn't just their beliefs and their behaviors and their biology that was causing premature disease and poor life expectancy. There was something that was going on in the neighborhoods. And of course, we've known for hundreds of years that what's called social determinants of health, or the structural determinants of health, account for 80%, or the other way to think about it, health and healthcare only count for about 20% of the outcomes. So if you live in the Loop downtown in Chicago, you can live to be in the high 80s in life expectancy and be ranked first in the world in terms of life expectancy. If you go down the blue line west, where I work on the west side, 7 stops and life expectancy plummets to under 69. And so that's not a disparity. A disparity is a difference. It's an inequity. And the difference between a disparity and an inequity is that inequity is inherently unjust. So inequality is an affliction all by itself. It is it's the epidemic of inequality that then COVID exposes. When in a place like Garfield Park, when I say it's a form of violence, structural violence, and it's structural because it's designed into the way our society works, our policing, our housing, schools, who gets what jobs, and it's violent because people die prematurely as a result. And I'll just end on this sort of note with that. In 2009, so that's now 11 years ago, my colleague, Dr. Steve Whitman, the late Steve Whitman, published data on excess Black mortality in Chicago. And it made the front cover of the Sun-Times. And in the front cover of the Sun-Times had a big number, 3,200 Black people die because of inequality each year in Chicago, simply because they don't have the same health experience as white Chicagoans. And of course, that number is the same number that died in 9/11. Every year in Chicago, by the way, that number was replicated in 2019 and it's still 3,200 excess Black deaths. That is a 9-year life expectancy gap between Black and white Chicagoans. It's the largest in the country. So what COVID revealed was the truth, but the affliction wasn't just COVID. It's structural inequities like structural racism. I call it economic deprivation, people who don't have a chance, and educational deprivation as root causes. And that's what we have to ultimately treat.
And that brings us, I think, back to the reporting. So Duaa and Akilah, I wanted to ask both of you about how you went about reporting this story and what patterns began to emerge.
Sure. So we knew that hearing from the families was going to be key. So we began by kind of doing everything we could to reach out to them, looking for phone numbers, social media accounts, obits, talking to relatives and close friends. And while we were doing that, we were also talking to doctors and people in the community. And like Akilah said, we weren't exactly sure what the story was going to say at that point, but we just wanted to do as much reporting as we could. And early on, I remember talking to a doctor who had said that she and others were seeing Black and Latinx patients coming in sicker and later. And that was concerning. And so on the next call with reporters and editors, we decided that we were going to ask the families that we were talking to if that was the case, and if so, why. And so I think that was one of the first patterns that emerged, that some of the families were saying that their loved ones had waited to go to the hospital until they were really sick, in part because that's what they thought they were supposed to do. So the CDC has emphasized staying at home when people have mild symptoms, because for the most part, most people can recover from COVID without going to the hospital. But what we found, and what the families and the medical experts were telling us, was that one-size-fits-all advice was problematic because it didn't account for all these other factors that, Dr. Ansell and Akilah were just talking about, the pre-existing conditions, the distrust of the health care system, financial concerns. And so doctors were telling us they wanted to see that advice tailored to African Americans and to have them encouraged to seek care and not just stay home. Otherwise, you're ending up with heartbreaking stories like one doctor who told one of our colleagues about her, one daughter, who told one of her colleagues about her father's death. She said he waited at home and he was dying already. So I think that was one of the first patterns that emerged. Another finding was that many of the victims didn't trust their neighborhood hospitals. And so these are safety net hospitals that, serve a large portion of low income and uninsured patients, regardless of their ability to pay. And so because of that, they don't have the same resources that other hospitals have. And so people who needed them most often didn't trust them. So they were either delaying care or going to another hospital that was 30 minutes away, or they would go to that hospital reluctantly and often only because that's where the ambulance took them because it was closest to their home.
You know, one of the things that I noticed was how the sentiments were echoing from Milwaukee to Chicago when you look at some of the larger kind of systemic issues that result in, like Dr. Ansell put it so eloquently, not just a disparity in death, but in equity and in inequality, and how people are living, but more importantly, how people are dying and catching, being infected by the coronavirus. And so, you know, it's this pattern of long-term generational disinvestment in community. It's a pattern of like Duaa was saying, communities not necessarily trusting their local hospitals, or the hospitals that are, when you talk about barriers and access to care, physical access to a hospital near you, they're under-resourced. The relationship with the community may be tenuous at best. There are some inherent biases just in how Black people and African Americans relate to their physicians, and, you know, distrust of the medical system. And then just in terms of like actual access to testing, because everyone, right, at the time, everyone was having a real problem getting access to COVID testing. And so that was then being even more exacerbated in communities of color and Black communities who, am I positive? Can I find out? Where can I get the test? Which hospital can I go to? What instructions am I supposed to be getting? So this whole kind of communication information gap understanding, like these are patterns that you were hearing in Milwaukee, and the city of Milwaukee was trying to address very early on, that you're hearing in Chicago. And then as I am continuing on this line of reporting, and as I've talked to experts all over the country, it's something that you're hearing throughout, you know, and people are saying that when you look at cities that have, experts are telling us, when you look at cities that have real entrenched histories of segregation, these are the types of patterns that you will tend to see because of the legacy of segregation that has been left in Black communities and communities of color.
It's easy, almost too easy, I think, to talk about the pandemic in terms of cases or victims, but it's critical to remember that these were individuals, these were people. And I think you learned so much about the individual lives of these first 100 victims in Chicago. Can you tell us a little bit about who these people were?
Yeah, I can start, and then Akilah, you can add whatever you think. But I think we were clear early on. We knew that their lives were going to be the heart of the story, that it was their stories and their experiences that were going to help us uncover the things that we did. And so we were really grateful to them for opening up to us. And it was really important to us to do justice by honoring their lives and kind of what they shared with us about their loved ones. And like you said, when we talk about racial disparities, you know, we need that data because it helps us speak with authority, but so often, you know, it can be easy then to talk about cases and numbers and statistics, but we really wanted to get to the people. And when we reached out to these families, we tried to keep that in mind because we were talking to grieving children and grandchildren and, you know, nieces who lost their surrogate fathers and sisters who were mourning their brothers. And all these deaths happened suddenly. You know, they weren't expecting this. And so we were pleasantly surprised at the number of people who were willing to talk to us and to share their stories. And I think in large part because they wanted to make a difference. They wanted these stories known so that people could understand what's happening. And so they told us about, you know, their lives, their loved ones' lives as nurses and respiratory therapists and church deacons and musicians and teachers. And there were, you know, I think we all, in the course of our interviews, had moments that were, you know, just really special in talking to and learning about these people, like I talked to Larry Arnold's niece, and you know, his story was tragic. He was the one who had a temperature of 103 and got in an Uber to go to a hospital 30 minutes away because he didn't trust the hospitals that were 5 minutes from his house. But his niece was also telling me about, you know, the good times and about his lemonade that was so good that people wanted him to sell it, and how, you know, he had this skill of making friends wherever he went. And so basically, whenever anyone would travel, they'd be like, hey, Larry, I'm going to this city. And he'd be like, oh, I know somebody there, you know, make sure to call this person. Or, hey, I'm traveling here. Okay, let me give this person a call and let them know that you're coming. So these were people who really were seen as pillars of the community and who were so beloved, and their loss was felt by so many.
I mean, like, that's the thing, right? So we start talking about death, and when we start talking about deaths in the tens and the thousands, they just kind of become numbers. And then when you talk about, so let's find out who people are. Let's find about, you know, these moments where fathers were playing video games with their sons who were freshmen in college and were home because of coronavirus and decided to step out and walk around the block in the corner and to get a change of clothes and never came home. And that's what happened with Asbury Sotomayor. You know, he will never see his youngest son play his first college football game, despite having seen every other football game that he had played, because he was a redshirt freshman, and so he didn't play his freshman year, and he'll be playing his second year. And that's a moment that now won't happen, you know? So there's a ripple effect of lives lost and communities that are, in a lot of ways, I don't want to say becoming destabilized, but there are definite gaps and vacancies. And then there's a whole kind of communal mourning that is also not able to happen with, you know, with the pandemic. Before this, I was reading back over just some of the thumbnails and remembering how special people were, you know, as you're talking about husbands who were sharing oxygen with their wives because they, you know, didn't have a lot of money. And when his wife was struggling to breathe, he thought, well, honey, we can do this back and forth. I'll take a few puffs and you take a few puffs, until it became unattainable. And then his wife had to go to the hospital and they never saw each other again, you know? There were mothers who had just thrown these massive baby showers for their first grandchildren and were there in the delivery room and were quarantining with their families, making sure to protect these innocent little babies, go to the first well visit. 10 days later, they're gone. You know, there are holes in these families' lives. And so I think that that's really important as we begin to think about just the amount of humanity that has been lost as we are telling these stories in such high numbers. And as we're thinking about, you know, and it's particularly as the conversation shifts to how are we going to reopen and where are we going to go next, there are people who are still actively grieving, and it has changed them fundamentally, and it has changed community fundamentally in terms of how do we begin to move forward and the lives that are no longer there and the ripple effect. And then how do you begin to keep people safe, and how do you minimize that damage and that harm moving forward?
So,
and it also speaks to the urgency of solutions, of the need to, people are literally dying every day, and they're not just numbers. There's, as you heard, there are husbands, wives, uncles, sons, brothers, sisters. And so there's an urgency to act, and there are ways to act. There are things that can be done. I mean, if you spend all your time wringing your hands about it, we actually, there are very, very specific actions that can be done, should be done. And some of them are local, and then some of them are national. And this kind of inequality and equity that we have, like I said before, is unnatural. It's not, because it's an affliction caused by our own policies, laws, and the way we do business. There is an excess sense of urgency around it. Because if the problem just resided within the individual, that they themselves, you know, were the screwing up in a way that they deserve to die early, well, then our work would have to be to fix the individual. But if it is in the way we organize things, then the opportunity is to actually do better. And we've shown for other types of health inequities that you can actually do better, and if not eliminate them, reduce them significantly. And that's the kind of work that's actually going on right now in Chicago. It's in its earliest stages. But the mayor, in response to these deaths, called for a rapid racial equity rapid response group. And my own work at Rush as a doctor for many years who've taken care of patients at safety net hospitals, which are not the same as an academic facility without the same resources. I understood that we couldn't make a difference unless we make structural changes in the neighborhoods around jobs, around employment, around educational opportunities, and yes, health and healthcare. And the mayor, we started an organization called Westside United, which has 6 hospitals, is partnered with community leaders. It's a racial health equity framed collaborative, and is aimed at reducing the life expectancy gap between the Loop and the West Side by 50% by 2030, not just by focusing on health and healthcare, even though that's critically important, but on economic vitality, the neighborhood structure, environment, and education. And the mayor called on us to sort of help with the response, and we're now partnered with the city in a response. It can never be fast enough, you know, because of the people sick and dying, but it is the right approach. And the key is to bring resources into these neighborhoods. So let me give you an example of one thing that we're doing. We decided that because of the historical mistrust and because of structural racism, that we needed to, all of the providers in the city, begin to reach out to all of their patients who are over the age of 65, not waiting for the patients to call in, but for us to call them up and to do 3 things in that phone call. One is, hey, how are you? How are you doing? And some information around COVID. Have you seen your primary care doctor recently? Because we'll schedule an appointment for you. And the third is, what are your needs? And then not just your needs for medication, but your social needs. Are you hungry? What we found from those phone calls, 40% have not seen a primary care doctor in the last year. And many of them are hungry. So we think that that sort of proactive approach is a critical, important approach. The city just announced new testing centers in the neighborhoods. Bring the testing to the neighborhoods, and so forth and so on. A lot more. Tonight I'm going to be in a town hall in Garfield Park at Westside Community. There's a town hall on COVID, and is organized by community leaders, Westside United. I'm going to be giving medical advice on it. But this is exactly the approach that we need to take.
Okay, so I'm going to open up the conversation to some of the audience members who have submitted questions in advance. Some of you are doing them right now. As a reminder, if you'd like to ask a question, please click the Q&A icon at the bottom of your screen to type it to us. But our first question was emailed in advance. It's from Kerwin, and he's actually sort of in contrast with the work that Chicago is doing around COVID-19 and race. Kerwin asks, why did it take so long for authorities to acknowledge that racial minorities were dying at a much higher rate? All of the early reports were just focused on the number of deaths and not the racial disparities. This isn't Chicago specific, but sort of the national conversation around COVID-19. Akilah, I know you reported on early race data around the virus, so could you take that?
I mean, that's one of the questions that came up early, and I think it's one of the questions that has continued to come up in terms of like, well, where is the data? And so at the outset of the outbreak, there was a lot of conversation just focused on raw numbers, international travel, and then kind of direct contact with somebody who may have been positive. And so around the time when we had our call, when we started to ask these questions about racial disparities, that would have been mid-March. So we were quite along, I want to say, in like, you know, mid-March is when we as an organization started asking the questions. And that's when I found out that community health researchers and people in the, like, whose job it is to focus on this, were also asking these questions. Where is the data? Why haven't we heard this? You know, the CDC usually leads the way on some of this. A lot of this information is standard in terms of what should be collected and what normally is collected kind of in a health sphere and is released. And so why hasn't that come out now? You had a lot of, and you continue to have a lot of politicians and elected officials, you know, Robin Kelly, Ayanna Pressley, Elizabeth Warren were early advocates pushing to get more release of federal data at a level. Like, why are we fighting so hard to get this? And I don't know that there has been a sufficient answer. I've heard many answers as to why it hasn't happened. I don't know that none consistent. You know, it eventually came up at White House briefings where this was an issue that was raised. And is this something that's happening? Are we seeing this? And the answer was like, well, yes, kind of like that. You know, like I think some of it initially was kind of met with a little bit of shoulder shrugging resignation, as in terms of these are disparities that have existed and they're really hard to tackle. It's entrenched, it's systemic, it goes back generations. We're in a crisis, we're in a pandemic. But then there's been pushback against that. Like, yes, we are in a crisis, we are a pandemic. There's a sense of urgency to this. And this is data that has, and these are data strands that have been collected and have kind of become root practice prior to the pandemic. So why isn't it happening now? And those are questions that are still being asked and still being raised.
And I would just add to that, I think that Illinois and Chicago are actually, you know, were one of the first, you know, in the country to release some of this data. It hasn't been perfect. I mean, I think the city early on realized that, you know, up to, I think, 30% of the cases were not reporting race, and that complicated things. So I think it's something that we have to keep pushing for, because we can't understand the problem in its totality unless we have comprehensive, accurate numbers.
Okay, and I also wanted to, we have a question about, will this be recorded? Will this recording be available after the streaming? And it will, to that reader. We have a question here from Dawn for Dr. Ansell. In your opinion, how does standard of care, where doctors have to keep doing what everyone else is doing, impact health and life expectancy as it relates to COVID-19?
That's a great question, actually. Is there more to it? I'm sorry.
Yeah, I mean, is there, I'm sure you would say yes to the second part. Is there a need for doctors to deviate from this during COVID to help more people, since, as we've discussed, one size doesn't fit all? And with, as it relates to COVID, like, what are some specific interventions, you know, that we can urgently do to deviate from this sort of everyone doing the same thing all the time?
Yeah. Well, on the one hand, there needs to be a standard care. And what you would find is there's probably a lot of variations, even in the story about someone, you know, I remember a man who was a double amputee who went to a local clinic, and he had diabetes and everything else in COVID. Now that's a high risk person. The standard of care for, you know, someone with a viral illness might have been to say, send them home. But given that it was a Black man, double amputee with diabetes, you would want to vary the standard of care and admit that person, at least for observation, to assess what their home situation would be like, to see whether or not they could actually isolate at home or shelter at home. I think we found this with a homeless population in Chicago, actually 77% of which, talk about racial equity, are Black. In Chicago, would go to an emergency room, they get tested, they're positive, and they get sent back to the shelter. Well, you can't, you must, your standard of care has to be tailored to the word equity. Health equity means those who need more should get more. On the other hand, you know, you do have places, and it was mentioned, safety nets that do not have the same capabilities as other places. And the standard of care for a patient who shows up at a hospital that doesn't have those capabilities might be for that hospital to transfer those patients out. But guess what? They try to, and many times the academics or the higher scale in terms of the technology hospitals aren't available. And so they get that variation of care in different neighborhoods. But I do think it's got to be tailored to the population. It's got to understand holistically their needs. So what might be work in a middle-class suburban area for a patient, even to shelter at home or isolate, isn't necessarily appropriate in a Latinx neighborhood or a multi-generational family household.
Our next question comes from Crystal. Social media posts have indicated that many African Americans are being rejected when they ask for COVID tests. Family members of deceased persons have said their loved ones were rejected several times before they passed. Has this issue come up in your research for the reporters and also for Dr. Ansell?
I mean, at the beginning stages, right? There were lots of, yes, like the short answer is yes. And then the question then becomes to break down and parse down the why, you know? Early on when we were hearing this, it was easy to kind of say, well, nobody can get tested. You know, everybody, tests were limited, they were being hoarded, they were being parsed out for these very particular, you know, high risk people here, that, and the third. But as stories have become out, which I think is the power of anecdote in addition to number, that we begin to hear not just because tests are in short supply, you know, that sometimes people are being turned away 2 and 3 and 4 times. And I think that has come up less kind of in our initial pool in Chicago, but more as we are hearing about it, like, you know, as stories are coming out of Detroit and as you're talking to and getting phone calls from people after the fact. I may have gone to the hospital, got sent home and told to kind of, you assume you have it. I know I heard that some in Milwaukee. People were being sent home with this kind of assume you have it till the test results come back, or assume you have it, and then if it gets worse, come back. And then throughout that time frame, people are beginning to deteriorate.
And I think what we were seeing in Chicago in terms of what our reporting showed us was that, yes, you know, at the beginning there weren't tests, but as soon as they did set up testing sites in some of these neighborhoods, the lines were around the block. People wanted to get tested. They just couldn't earlier. And when they would go to the hospital, you know, we heard from at least one family who said, you know, their loved one was sent to the hospital, they were sick, and then they were sent home and they weren't tested for COVID. And that's what made her so angry. So I think this gets back to this question that Dr. Ansell fielded about standard of care and what that should look like for this population.
So you can almost predict, given an unequal society, that in scarcity or in abundance, those resources will be differentially available. And that's what we found. So there was a number of reasons. One, in the beginning, we didn't have enough tests. And so a lot of times people with symptoms said, you know, assume it. But where there were less tests were in the neighborhoods. And at the neighborhood, even at the neighborhood hospitals, the big hospitals like a Rush or Northwestern or U of C in Chicago could actually set up their own testing. And suddenly we're doing, you know, hundreds and hundreds a day, whereas at a federally qualified health center in the neighborhood, there were none available. So these gaps were just exacerbated, and that's how structural racism perpetuates itself through the maldistribution of resources that are, you know, almost just done as a matter of consequence of who's got money and who doesn't to purchase the machine or the testing stuff. It's a criminal in a country that's as wealthy as ours that we've tolerated this. And I think I like to remind people after 2008 crash, in which the number of unemployed were about 8 to 9 million. Now we have like 35 to 40 million. The Wall Street protests came out, and the issue there was the 1% versus 99%. That is the issue here, is the issue of this just gross inequalities and inequities in the United States that lead to these maldistributions, that lead to people not having access to the simplest of tests. That is at the root of all of this, and obviously disproportionate with Black and brown folks, but largely an American insolvable problem.
So we have a couple of questions that are kind of similar from Elaine. I'll read Elaine's shorter version of it. So we're talking about, these are long-held disparities that have been going on well before COVID. So what gives us hope that this connection with COVID-19 will finally address the problem of like the structural issues? And Daphne sort of says more on this. She asks, like, why would the collection of more data change anything? It's systematic. What really alters systemic issues like this? Is it public policy? Is it public or civil lawsuits? You kind of like give us some hope for like what's going to really move the needle on this.
Well, I'm going to jump in first in this, unless you're. So first of all, I think you're right. I mean, we don't need more data. What we need is more intentional actions. I think writ large, what we're going to find after COVID, a country that is poor, with large numbers of unemployed in it, a healthcare system that is going to be incredibly damaged by this, because it actually taking care of sick patients all across of America bankrupts healthcare systems. And I think we're going to have to ultimately come to a reckoning around the way to finance healthcare. So one point of access to care, and I have some hope on it, especially if the next national election goes the way that I'm hoping it goes, that we'll end up with on our way to a single payer type healthcare system. Because some of the problems are complicated as well by the insurance or the lack of insurance that people have. And so I'm kind of optimistic that the state of the country is going to be such it's going to require some kind of national solution. I am heartened by the fact that we have a mayor in Chicago and folks in other places who have looked at this and made racial equity a cornerstone of their policy. So before COVID in Chicago, Mayor Lightfoot had her Invest Southwest, that the idea that is capital reinvestment. Capital has been removed from these neighborhoods, and as a result of this capital removal and the lack of investment, I don't like the word disinvestment, it sounds so passive. Capital was removed, and then we never put it back, and then people die. We have a mayor in Chicago who really understands that, ran on that platform. Doesn't mean it's going to happen easily or quickly, but there's a lot of attention into the city about reversing these decades of disinvestment. So I'm optimistic about it. And the third reason I'm optimistic is because we've shown for breast cancer disparity in Chicago, where there's a mortality gap, that if you go in and you just get places to apply a standard of care, that we can make the difference in who lives and who dies. And we know that can be done for other things as well. So it's not going to happen overnight, but optimistic that we actually have the tools, and being aligned around the idea that racial equity is a goal for a city is makes me tremendously optimistic that we can make a dent in it this time.
So our next question is from Tanya. It's about actually your reporting methods, Duaa and Akilah. They wanted to ask if you use online reader engagement methods, such as reader callouts, to identify sources for reporting. If so, what method did you use and how did that work?
So we've used callouts a lot just in our reporting with COVID. We've used it for a number of different stories. I don't think it really came into play with this specifically because we were so focused on the 100, but it's been really helpful kind of in the background to help give us information and kind of food for thought as we approach this. And I think that hearing from nurses and healthcare worker call out has really helped inform our reporting.
I mean, as did online, right? Like, so as did not just the call out, but then if we're looking to go to digital communities and digital spaces and where people live in kind of a digital way, that very much informed our reporting on this as well, to give us a fuller sense as to those first 100 lives lost, in addition to the people that we were able to have direct contact and communication with. And I kind of wanted to piggyback on that last question a little bit about hope for future as well, because I think one of the things that has come up repeatedly in this reporting as what history we should have known because of history, and what history has taught us through past pandemics, and what history has taught us and previous heat maps have shown us, and what we should have anticipated for COVID. And so I think some of those same people who have raised what history has told us have also raised what history has taught us is how you begin to make change is to continue to push and advocate and push on the levers of power for the people who actually have the ability to make change, right? And so If I can take an example from previous reporting from a former life, when I was a reporter at the Boston Globe, I can just take a small snippet. We did a story on race and racism, and we looked at how in the city of Boston, in the state of Massachusetts at the time, there was so much of a concentration of political power didn't exist within the Black community, and there were so few Black kind of elected officials and people in boardrooms and really at high-ranking positions. Well, fast forward to now, where I've already mentioned that Ayanna Pressley is one of the people who is advocating actively in Congress to have this information data released. But she's not just asking for data's sake. She's asking that resources then follow the data, and that the data informs the response. And so to piggyback off on what Dr. Ansell has said, that right, like, so that you can figure out which communities need the most help, and they can get more resources. And so if you're looking at how do you begin to change a situation, you begin to change a situation by constantly activating, agitating, and pushing and calling for things to get better. And I think that's what the advocates and activists and elected officials that we have spoken throughout this are constantly reminding people of, in addition to the lessons that history has taught us of who dies first and who is most impacted by pandemics, is how do you then begin to change that situation?
And just to add one point to that, Akilah, so the conversation, I think, has shifted, and there's been a lot of talk about why this is a problem and what needs to change, but it's really taking it to that next step of seeing that now be implemented in policies and, you know, financial resources to these safety net hospitals. That's what I think is going to need to change.
So it's simple. When you think of health equity, this is an interesting, why would a doctor like me, whose practice I was chief medical officer at Rush, I was worried about the hospital, to go and sort of focus on health equity, because it really comes down to, if you really want to save lives and have a fairer society, it comes down to power, it was mentioned, resources, and money. And we actually have the ability to do all of that. And you've got to follow where the resources go. But it's got to be intentional. Back to the earlier question, public policy around this, and so it does require political power. If we didn't have a mayor like Lightfoot we wouldn't be aligned on racial equity thinking. But she has a budget deficit of about $1 billion before COVID, so it's going to require the resources as well to make this happen. But this is why all of us as citizens is so critically that we be active, and why journalism like this article is so important, because the narratives are important, the data is important, but without actually action, we're not going to make these changes. And the action is often political action. Just like there are social determinants of health, there are political and economic determinants of health, and it requires us all to be active in achieving these outcomes we want.
Our next question comes from Mara. Are there any groups tracking the deaths among undocumented immigrant families? And can you share that information too?
In Chicago, we've seen, this outbreak moved. Think about it. It started with the people who traveled, right? Everyone said, do you have a travel history? And then you stopped asking that. Moved into the Black neighborhoods. Now it's moved into the Latino neighborhoods. You're going to see in the next couple of weeks that the case rates in the Latinx community are going to exceed that in the Black community, and then you're going to see the death rates climb. It's hard to know who's a citizen and who's not a citizen, because in our state, thank goodness, that's not a requirement to get into a hospital or not. But you can assume that the same kind of conditions will affect mortality in Latinx neighborhoods as well. It's a giant outbreak going on right now. That's and because of the way people are living in multi-generational families and working in closed quarters, that causes rapid spread. But I don't think anyone in particular is able to count undocumented.
And that's one of the things that we haven't really touched upon, this issue of work. And so for a lot of brown and Black communities, you know, they are working in jobs that are considered essential. So in, you know, factories and grocery stores, and a lot of those people are also undocumented. So that's something that we definitely need to keep watching as we move forward.
Yeah, they became essential during COVID, but it was never essential to pay them well enough to avoid, lives that border on the edge of poverty.
And the state of California, I think, is one of the few that has made it a point to really call out and say that I think that they set aside a pocket of money for folks who are undocumented to receive care as a result of COVID-19. But I don't know right off the top of my head. Like, I know of organizations that are tracking deaths writ large, or, you know, looking at ethnicity, but I don't know anybody who's who's following immigration status specifically.
Okay, I'm gonna do one more reader question before we have a closing question from Louise. From Daniel, and this is maybe one for Dr. Ansell. Did racial assumptions among doctors and nurses contribute to the inequity in death rates among Black and other people of color? So we talked about the systemic issues, but they're asking, you know, actual like cultural assumptions being a part of this.
I like to talk about, you know, when you talk about racism, there's interpersonal racism, you know, the overt kind, and then there's unconscious or implicit bias, ways in which we might unconsciously treat somebody different than someone else. And I'm certain that played into decisions. But I like to say the most dangerous form is the structural or institutional racism that you know, is embedded into our systems and structures and operates almost invisibly. And I worry about that. I think we can change people's, we can do work around bias, but I think our work really has to be aimed at both changing people's attitudes, but changing the structures that are kind of self-perpetuating structures that persist, that make a safety net hospital, the wait times perhaps longer, or maybe you might slough off a complaint because it's overcrowded and busy. I worked at Cook County Hospital for many years, and you know, the conditions there or in safety net hospital are very different than in, you know, an academic medical center like Rush, where I work now. And so I'm mostly concerned with the systemic aspects of how this gets perpetuated, because I think more people die as a result of that. Not to minimize unconscious bias, I think is there as well.
Okay, so I'd like to have Louise close out the panel to get some closing thoughts with the last question.
Sure. So thank you to our audience for these thoughtful questions, and to the three of you for this informative and wide-ranging conversation. So as we wrap up, let me ask each of you this. What one point or lesson would you like our audience to take away from this conversation? And I'll start with you, Duaa.
I think for me, the biggest takeaway is that their deaths were not inevitable. I know COVID-19 is an awful, awful disease, but you know, as we learned in the reporting and as we discussed today, there are systemic factors at play, and it might be easier for us to blame their deaths on their underlying health conditions, you know, but it wouldn't be right without examining, you know, why those health conditions exist in the first place, without understanding the consequences, you know, of structural racism and, you know, diminished opportunities in these communities. And so I think that we just have to remember that these were not inevitable. It did not have to happen this way.
And it doesn't have to continue happening this way, right? Like, it didn't have to happen, and it doesn't have to continue happening. And so I think one of the things that I am quite often brought back to is the need for intentionality, right? Intention and impact. The people have the best of intentions, but your impact is quite different. And so yes, everybody is hurting right now, but the size and the impact and the level of harm that some communities are feeling is vastly different, and it does not have to be that way. It did not happen by happenstance. It just didn't happen, and it won't change by happenstance either. It takes intentional action and forethought.
Yeah, I would echo both of those points. These are not inevitable systems. These are intentional. These are afflictions. People are being oppressed by the systems we've created and we've allowed and we've tolerated in our political and economic approaches to the world. It's up to us to change them, and they are changeable. And I think that's, to me, the note of optimism here is it's unacceptable, it's intolerable, but with intentional both health policy, but other public policies, particularly around resources. And I think we have a particularly toxic form of capitalism here that values property over people and has from the beginning of time, but there are more fair societies with the same economic system that have fared way better in this epidemic and other things. So that sort of intentionality about system change that has to occur at the national, but also at the local level, and our intentional actions in neighborhoods regarding human capital. I say there's three kinds of capital we have to invest in these neighborhoods. Personal human capital by showing up in these neighborhoods and purchasing things and supporting the businesses there. Social capital by all of us doing it together and creating the nets that are needed around neighborhoods, food, exercise, other things that make them happy. But real capital, which has been taken away from these neighborhoods. And so we can reverse these acts of affliction.
Thank you.
Okay, so we actually have a few more minutes left, so I'm going to allow a bonus question. And we actually had a few people ask the same line of questioning. And this is about your reporting on a really sensitive topic at a very delicate time for your subject. So given how recent the deaths were and how many funerals were limited, and especially painful given how gatherings weren't allowed, how did you balance the responsibility you felt to reach out and report this story and also the balance with their grieving process?
I mean, I think that's right. That's something that I think reporters kind of often battle with, particularly with sensitive issues like this. Radical empathy is kind of something that I choose to enact whenever I am in a situation like this. And you have to understand that people have the ability to say no. So you just come to people with radical empathy. You're there. You want to tell, as much as you'd be surprised by how often people want to share their family story. People want to tell you what happened. They want the world to know what happened to their loved one. They want people to know that these were not deaths of happenstance and that things could have been done. And so I never kind of go in with assumptions. You go in assuming that people want to talk to you or not wanting to talk to you, but you have a job to ask questions, and you do it with an open heart. You have to do it with an open heart in a situation like this, and you have to do it with a lot of patience, a lot of humility, and understanding that if someone says, no, I have no desire to share any of this information with you, please stop calling, or why are you calling, that you say, I'm sorry, I completely understand. You know, my apologies, I never meant to upset you, and then you back away, you know, but more oftentimes than not, it's like the knocking on the door. People open the door and let you in at their most complex, vulnerable moments, and it always is a humbling experience. But people want to share their stories. They want their loved ones to be remembered.
I agree with that completely. I think the only other thing that I would add to is the power is in their hands. You know, when you're interviewing an elected official, you know, you're not as understanding, you're not as, you know, empathetic. You need the answers and you want them to, you know, answer your questions and hold them accountable. When we're reaching out to these families, it's really on their own terms. You identify yourself, you try to explain the story that you're working on, why you're doing it. And if they want to talk to you, then like Akilah said, you are patient and you listen to them, because they might go on for, you know, hours talking about their loved ones, and you're there to listen, because sometimes they just want somebody to listen to them and to hear them out. And so I think that's, you know, that's key, is just letting them have the power. And if they decide, you know, actually we changed our mind, we don't want, you know, our loved one to be featured in this story, then you say, okay, that's okay too, because I understand. And thank them, even if they decide to change their mind, you thank them for the opportunity of, you know, sharing that with you, because no matter what, it's going to inform your reporting.
Absolutely.
Thank you for that. So that is now our time for today. Thank you to our speakers for sharing your time and your expertise. Thank you also in the audience for coming. ProPublica will continue reporting on issues of coronavirus and race in the weeks and months ahead, so please do continue to follow our work. And from all of us at ProPublica, thank you for tuning in and stay safe. Bye.
Thank you.
Thank
Thanks,
you.
everyone.